Good evening, everyone. Welcome to this session of web-based learning from the members of the AO North America Hand Education Committee. We sincerely hope that you and your loved ones are managing to stay safe during these surreal times. My name is Chai Mudgal, and I'm very delighted to offer you this bi-weekly series that we have called Sage on Stage. Every 2 weeks, we will get a chance to hear from sages who are hand surgeons who have made seminal contributions to the field that we so love and made us better surgeons. Their thought processes, their experiences, their missteps, and their technical pearls and pitfalls are what we are going to gain over the next hour. Our inaugural sage does not need any introduction. He is my friend, my colleague, my mentor over the last 30 years, and he will talk to us about a variety of issues. We will have questions being moderated by Jay Bridgman from Columbia, Missouri. Disclosures and potential conflicts of interest have been resolved. A little Zoom etiquette, all your microphones have been muted and your videos have been turned off, but your questions should be sent to the Q&A section at the bottom of your screen, and Jay Bridgman will moderate them and decide what to pass on to Dr. Jupiter. With that, I'm going to stop sharing my screen and turn it over to Jesse to share his. And Jesse, we're going to kick this off with what I suppose is your favorite topic, distal radius fractures, although I could be wrong. So here's my first question for you. How do you radiographically assess a fracture of the distal radius, and when would you get a CT?
Okay, well, thank you, and greetings to everyone. I just want to give you a very brief history, and if you look over to your left, that's me as a chief resident in 1979. And I'll tell you what I wish I knew then about distal radius and elbow trauma is, first of all, how to read x-rays correctly and to recognize the difference between fracture patterns. Some fractures of the distal radius are so different that the only thing they have in common is that part of it involves the end of the radius. And we'll also touch on some specific fracture patterns. Interestingly enough, the treatment at that time was just do a closed reduction and follow the patient along. And that younger patients with intra-articular fractures would probably do well because it's not a weight-bearing joint. I think it's clear that times have changed. Some years later, with a colleague in Switzerland, Diego Fernandez, we produced a book, the two of us, on this. And my chairman at that time, Henry Mencken, pointed out, why is there so much about so little? The book was 320 pages, only on distal radius fractures. And it's really just a small part of the body. It's not really life-threatening, but it's something that we don't often do well with. And it's a little bit different now for many of us and many of you because things have evolved to such a degree that with an unstable fracture, for want of any other way, we tend to try to get a volar plate on there. But the real question that Dr. Mudgall's addressed is, how do you assess these and when do you get a CT scan? I think the real reason is to try to figure out which is an unstable pattern, which won't do well with a cast per se, if you're trying to preserve anatomy. And for difficult fractures, we know that when they've got a good deal of instability patterns, they won't hold very well, even if you get, as illustrated here, a very nice initial reduction. So how do you assess this fracture? What are you looking at right now, those of you in the webinar, and what do you think are the problems here? Well, part of it and part of the assessment really is understanding the anatomy. And what we've come to realize is that the volar surface of the end of the radius is not square across by any means at the very terminal part. The radial styloid and the lunate facet are both separately inferior to the long axis of the radius. And as a result, it's not very easy to judge the position of either one of these from a regular X-ray, and particularly the lunate facet. If you look at this volar instability pattern, this is the so-called shear fracture, it's pretty easy to understand what's going on. But when we looked at a whole group of these patients, about 44 of these, we found that the vast majority of these, that volar fragment is not simply one fragment, but often has two. And sometimes the lunate component is very distal, which means if you tried just a standard volar plate here, it may not support that so-called teardrop area. And we know that in this case, the carpus needs to be pushed back up to reconstruct a normal alignment. If you have an axial pattern, not a shearing, but an axial pattern, look what happens. If you look at here, it's very hard to tell how displaced that volar fragment is. But when you start to measure, and if you look at what's called a teardrop, you realize that that's a rotated volar lunate facet. The normal angle between the longitudinal axis and the teardrop should be somewhere about 70 degrees. And when you start looking at this, it's clear that that's a rotated fragment. These are nice illustrations from Bob Medoff in Hawaii. And so the axial instability pattern is very hard to tell from routine x-rays, standard x-rays, and often a CT is very, very helpful, as well as with the volar instability pattern, because that too may involve more than one volar fragment. So if I can leave you with something, it's that volar teardrop that's really hard to assess accurately without a CT scan. And we know that for many studies throughout the musculoskeletal system, scanning improves the alignment. So this was the x-ray I showed you, and it's probably not so easy to tell that there's a volar lunate facet that's displaced and how the lunate has pushed down this relatively small facet. And we can do a 3D CT as well to give a better feeling and maybe more effectively treat that. So any discussion, Chai or anyone else?
That was fantastic. Jay, anything in the pipeline there?
No, no questions yet.
Good. Then let's keep going because we have got this fountainhead of information here.
Okay, so the next question you asked me was some tips, particularly for the intermediate column.
That's right.
And we should talk about, to know what we're talking about. And several investigators started to try to figure out that the weight-bearing surfaces and the articular surfaces can be viewed in terms of different components. And we'll look at that, and the column may be the radial column, intermediate column, and ulnar column, with the intermediate column being the support of the lunate per se. Well, when people looked at this and thought, gosh, that bone on the radial side is the strongest, so more likely than not, there's a good deal of weight bearing that's going to be borne by the radial column. But if you look at this, realize that on the radial side, it's really the origin of some of the major volar capsular ligaments that come across the carpus to prevent ulnar subluxation of the carpus, where really the weight bearing is primarily is the central or intermediate column. And this shows you what happens in studies. We base so much of our information on non-physiologic studies. In several investigators looked at this trying to bear load on cadavers with a straight axial load. And it all suggested that more weight and force was borne on the radial column. An absolutely unique experiment was done by Daniel Rickley in Switzerland, where he somehow got his IRB to allow volunteers who were paid to have a light anesthesia, and then he inserted a force-bearing film while they were still not completely paralyzed, and asked them to move around their hand and wrist. And he got measurements all throughout in extension, flexion, deviations, and whatever. And he showed without question that more forces were born on the intermediate column than in the radial side or the ulnar side. Now that makes a lot of sense, because the whole way the wrist works is to prevent the lunate, capitate lunate axis from going too far one way or another. The scaphoid flexes when you go into radial deviation, extends when you go into ulnar deviation, but we don't want that lunate capitate axis to deviate too much, and it's the support into the lunate facet is really where weight bearing has occurred. The radial column is a little bit more important for the insertion of the ligaments. We know that sometimes we'll see an avulsion of the radial component associated with ulnar translation or scapholunate ligament. Rarely will we see a compressive injury, but we will see a compressive injury in the intermediate column. And what the intermediate column does, besides bearing load, is it's the articulation into the ulnar head. So failure to get these reasonably close together can affect a rotation as well. Well, what are some of the ways to do is analyze this with CT scans. CT scans will show you very effectively not only the extent of deviation of the metaphysis, but really an understanding of the lunate facet. Sometimes we need to go and do it small plates on both sides. Sometimes we can't do everything with a volar plate. If you get CT scans post-op, you would like to be able to see that it's not bad. We don't often get that CTs after surgery, but sometimes they're very helpful. And motion and rotation can be restored. You can't always do it through a volar plate, as I said. Here's another case. You can see that this teardrop, how rotated the lunate facet is. There's a central impaction, and this is the dorsal lunate facet. And if you look at this, seeing this sclerotic bone area, that's the joint surface rotated. And so look at this lower picture here. That dorsal lunate component is rotated 180 degrees with the cartilage facing the elbow. Very hard to do these with just a volar plate, and it's very mindful and to understand the dorsal anatomy, and through a small incision over the intermediate column, one can push that back. In those cases, though, it's far better to stabilize the volar side first. Otherwise, when you try to support the dorsal lunate facet with a plate, if you don't have something below, it may not work very well. And this is a good follow-up in 1 year. The other alternative is this compression clamp that the DPS has. And what you can use it as, once you've applied your plate and reduced the volar side, it's a ball tip clamp with a dorsal radiolucent component on the top. So with the volar plate in place, stabilized with either a clamp or 1 or 2 screws, apply that ball tip clamp with the radiolucent dorsal side that wraps around the ulna and will compress the lunate facet, as seen here. Additionally, it helps restore the volar tilt to the radius, and this that patient reduced, and here's the post-op CT scan. So that's some ideas about the intermediate column.
So Dr. Jupiter, one of our
Jay,
attorneys has
yeah.
a question, and that is, if a distal radius has a non-displaced volar ulnar fragment, would you consider fixing that? Or is there a decision-making algorithm where you might stress that under fluoro to see if the carpus is unstable? How would you address it's a volar ulnar fragment that's non-displaced?
Oh, and there's no other deformity, no other fracture in the end of the radius?
Yes, are those intrinsically unstable essentially? Like if someone has a non-displaced volar ulnar fragment, is there some worry that it might displace later, and so it should be, fixed because of that possibility?
Well, I guess if it's a higher energy trauma and there's a lot of soft tissue swelling, it may be an indication to do surgery. If it's an older person, you can afford to watch that. But that's a good reason to do a CT scan.
It's great. Thank
Okay.
you. So the next question I had posed to Dr. J was, is the monoblock volar locking plate being overused? Should future generations be well versed in closed pinning as well?
Well, why is it so good, the volar plate? It's so good for most cases because it's based upon the concept of angular stable fixation. Many of these fractures are in osteopenic patients, and prior to the angular stable locked fixation devices, screws would loosen. We used to do try to do plates on some of these, but this is often what would happen because the screws were not sufficient to really prevent instability, prevent loss of fixation. And as a result, we couldn't afford to stabilize effectively internally a lot of patients with this problem. That is, patients who are older but active, and we can avoid the cast. What the fixed angle does is it really transmits the stress to the plate through these buttress pins or screws. So we're not fixing as you would normally with a screw. Why is it used so much? It's used because it works. It's a transformative technology, and it's influenced the care of patients throughout. Its shearing fractures, as I mentioned, don't always need a standard volar plate. They can be effectively done as long as you recognize that there may be more than one fragment. Here's the follow-up. But the literature's conflicting because we started to see patients treat and put in prospective studies. This is one from Austria, and they looked randomized to cast, closed reduction in cast or volar plate, looked at all the outcome measures in physician and patient rated. Patients were 65 years and older. And remember, this is in Austria, these surgeons are AO trained, do a lot of internal fixation. So if there was any bias, it would be in that. And they found no significant difference, pain or range of motion. Patients had a lower DAS score and wrist and function score early, but no significant difference later on. But the anatomy was better, but the complication rates were higher in the operative treatment. So their conclusions in this prospective randomized study was that there really wasn't a big difference between these two groups, and that achieving anatomic reconstruction didn't always convey a better result. So really the question then comes when you ask, are these plates overused? how perfect does an X-ray have to be? Take it a step further. This study from England, where they looked at a long-term follow-up, averaged 38 years in young people, excuse me, who were then followed 38 years later, all treated in casts. They all had malalignment. They all had evidence, or many had evidence of osteoarthritis, but the DASH scores were not different than population norms, and pain was not so much an issue. So this study challenged the idea that you really had to get an anatomic reduction, even in a young patient. And this was also confirmed in another study out of St. Louis and in a study out of London, Ontario, where they showed patients over the 65 seemed to tolerate it pretty well. However, you could look at it the other side and say that in active patients who want a better chance of motion and less pain, there is evidence, although not the threshold of statistically significant, to support the plate. We do know in several recent studies from Sweden that clearly patients who develop a substantial malunion, even if they're over 65, do have some problems. So in summary, is it overused? It may be, but it works. And if used correctly in the right circumstances with good analysis of the fracture pattern, it still remains a very viable treatment.
Great. Should there be an emphasis on making sure that future generations are at least technically sound in pinning fractures of the selected fractures?
Well, let's look at that. Okay, so is it effective? Yes. Dr. Mudgall and I have had quite a long experience with this. And in good quality bone, with not a great deal of comminution, it's exceedingly effective. This was started a long time ago in Europe and then in the US with a variety of methods. The Campanji technique described a way of using your K-wires to help reduce the fracture and then pin across it. It didn't work as well with in osteoporotic patients. For years, even with 2- and 3-part articular fractures, we can reduce the radial column and reduce the lunate facet. If you want to look at it arthroscopically, it may be very helpful, and then pin across. Protecting these pins either with a thumb spike, a cast, or an external fixator. Fixator left on for 3 or 4 weeks. And this patient had that 3-part articular fracture. And this is at 3 months. He has very, very effective and good outcome. So yes, people should be familiar with that. And then let's look at the data. This was a prospective randomized study, volar plate versus conventional percutaneous methods, using external fixation, which is you have to neutralize these pins in bad articular fractures. And they followed these as a randomized study, looking at patient and physician rated outcomes. And guess what? No difference at 12 weeks or 1 year between the groups. The grip strength was better in volar plate, X-rays better, but the overall function was the same, and no difference in complications. So I guess there's enough evidence to say that that has worked in randomized prospective studies. And the latest to come off is from the UK, where they have a large study that was prospective, looking at a variety of trauma centers, looking at K-wires and casts or locking plate. and I won't go through the data, but they found no significant difference with this. But K-wires are cheaper and quicker to perform. So yes, it's a good thing to do. We may be challenged, we're going to be challenged with just about everything we do. And if we can get to do a beer block or something, or an outpatient in a procedure room, as opposed to having to have a more extensive anesthesia and do percutaneous pins, it may be both economically better and may allow us to do more in the face of limited access per se. So to answer your question, yes, we should all know how to do this.
Great, thank you. Jay, any questions?
Yeah, so I have a few. So in the older patient, they're 65 or older, when you're evaluating them as far as their activity level, what are some guides that you use that would tell you this person is active and I'm leaning more towards a volar plate versus those that are not as active, that you'd lean towards either non-operative treatment or pinning?
Yeah, I think I can answer that question by looking at a group of patients that we studied, looking at an outcome tool that asked patients to what type of functional tasks do they do? What were they doing? Were they playing tennis, golf, et cetera, gardening, and looked at that as a measure of how much you would want to restore their anatomy. And I think that we should all do that. We don't look, and they weren't being looked at chronologically, but physiologically. Yeah. And I think that's the answer that probably people should take home.
Okay.
And
so shall we move on to the next one, Jay? And then we'll come back to a question after this one.
Okay.
So the question was, are we span plating too much?
Yeah. Well, I think the interesting thing about span plating is the history. And Jim Beckton is an orthopedic surgeon in Georgia, and he developed this plate many years ago. And some surgeons, particularly one group in Detroit, did this for almost every displaced distal radius fracture. And they kept the plate on 3 to 4 months. And you'd say, my goodness. But I reviewed about 300 of their cases as a discusser at the Hand Society. And guess what? The patients did extremely well. And as a result, I think that it almost doesn't make sense in that we would want to get the wrist moving. But the downside may not be as bad as it is. But this is a development that was predicated before the volar plate. Because what the volar plate did more than anything else is for independent, active older people to remain independent, to avoid immobilization of nature, to avoid swelling, to mobilize the forearm. Those were all things that were very commonly problematic after immobilization. And so I think that where this has become most useful is for very unstable fractures, thinking about it as the concept of the pins, where you needed an external fixator to neutralize. If you look at these two investigators and their papers, the vast majority of these were done in patients who had very unstable situations, a good deal of soft tissue injury, often with volar components to the fracture that you actually need to plate the volar side first. This is a very unstable fracture in a young man. He had a decent, but not perfect, manipulative reduction and then stabilize with the plate. And so, especially in situations of a good deal of soft tissue trauma, it is effective. But if you want to do it as a main line, there's enough evidence to support that as you first go. But I don't think it's necessary with other methods.
Question, Jay?
One of the attendees asked about what's a typical timeline that you like to start wrist range of motion for the standard volar plating?
Well, it depends on your patient, really. There's enough evidence for several studies that it probably doesn't make a difference if you move, within 10 days, if you move within 3 weeks, if you have the patient move even at 4 to 6 weeks. Patients who are uncomfortable, who have anxiety about moving, there's no rush to do that. What is important is to minimize the swelling and maintain a good hand function, and even early on. Everyone has a different way, but I don't think you need to use casts in association with plate.
Great. Dr. Jay, next question. What is the role of carpal tunnel release in distal radius fractures, and does it positively influence digital motion? When would you do it?
Well, if these studies that show pressure on the nerve, if you had ever reviewed the literature or had opportunity to see patients who were put in a cast or splint with the wrist flexed, bear in mind that increases the pressure in the carpal tunnel substantially. And people have looked at that and looked at patients having had pressure monitoring in after they've had a reduction of their fracture. And those patients who had high pressures tended to not do as well. One thing to do is check to see the sensory, either light touch or vibratory test. 2-point discrimination is not really the first line of sensory testing. It's not that common. This study of over 500 patients, only 23 had median nerve symptoms, but it can be problematic. Here's a study we did using implantable cement, and when we found out how patients had pain, we found that a certain number of patients had carpal tunnel pain. And the answer is, if you have pain that's out of proportion to the injury or to the treatment, you should think of the median nerve. And those patients with excessive pain, if it's unresolved, will likely have a higher chance of getting complex regional pain syndrome. So my recommendation is, if a patient has pain out of proportion, do all the normal things, take the cast off, get the wrist out in neutral, but avoid this kind of problem. If they still have the pain, go and release the median nerve. I did a study years ago, but I found that the median nerve compression, unrelieved, had a very strong negative effect on outcome, and early recognition is the single most important predictor of outcome. So if I see a patient who has pain out of proportion after their fracture's been reduced in the emergency room, has dense sensory loss, I think they should have their median nerve released and their fracture fixed, of course. If a patient comes to me after a week or two and has a severe pain, I think it's the median nerve, and it should be released. So have a low threshold for releasing the median nerve because the sequelae are very bad.
Great. So moving on to the last part of the distal radius section.
Okay, what does this mean? There's an interesting study out of Austria where they loaded wrists in extension with an instron machine, slowly loading the forearm and taking cine pictures. And guess what? The patients who had fractures that were extra-articular tended to have all their carpal ligaments intact when they dissected. The patients who had intra-articular fractures, the supposition, what they thought was when they explored them surgically, the cadavers, they found many had intercarpal ligament stretching or tearing. And this was their study. Look how many problems they saw. Now, you couldn't tell which was there before, but frankly, it was likely to occur because that's how you had asymmetric loading. And this has been shown on arthroscopy. We know that when you have these avulsion, like the Chauffeur's fracture, you may have a scapholunate ligament. And in those cases, if you have a complete drive-through, then that may be part of a transstyloid perilunate injury, per se. If you have traction and you see a major asymmetry between the scaphoid and lunate, that may suggest a traction. That's called Galula's line that can be disrupted. And we looked at that years ago radiologically and found that certainly there are situations that you see that. Now here's a sports injury. Here's the X-ray and the CT scan showed a wide gap. So how do we manage that? Well, you can do an arthroscopy. You may see this. You may see that it's not necessarily completely ruptured, but some people will go ahead and treat it anyhow, as done here. But what about this patient? Very much the same. One thing to always remember is X-ray the other side. So this is the CT scan. It was fixed because this was the other side, almost exactly the same scapholunate gap. And this is at 36 weeks, 72 weeks with a good function. Here's another patient. Here's the X-ray. Same thing. So X-ray the other side before you judge any other ways. And here's at 45 weeks. Another patient. Look, here's a CT, the X-ray. See the wide gap, fixed like that. But look at that. That's a normal gap. Should this be treated? That's the real question. Probably not. Probably not, because I don't think in a standard distal radius fracture that these are complete scapholunate ligament ruptures. The ones that are complete ligament ruptures are usually a type of perilunate injury. So it's not very common, and as a result, and the telling thing about that was in this study by Lindau's group in Sweden, where they looked at 51 consecutive patients and 32 of 51 had SL ligament tears. And they followed those patients. None were treated surgically. And guess what? They found that the ones that were not treated did just as well as the opposite side. But none of those patients had this complete tear that I'm talking about. So if there's any question, X-ray the other side and consider arthroscopic evaluation. More likely than not, it'll be an incomplete lesion. Okay?
That's awesome. So we'll move on to proximal ulna.
Okay.
Should complex proximal ulnar fractures be eponymously addressed anymore, or are they oftentimes a continuum transitional lesion between various injuries?
Okay. Well, this is what we're talking about. We're talking about this pattern of injury. Remember that besides it involving the diaphysis to a certain degree of the ulna, it involves the proximal component, which is both ligamentous and articular. So bear in mind that some of these injuries will have combination of joint dissociation and ligament injury. Remember too, when you're treating these, that the ulna is not straight. It has a dorsal angulation of about 7 degrees and a varus angulation as well. Just keep that in mind when you're treating those. Many years ago, Beto, looking at pediatric type fractures of the so-called Montigia, realized that there are different patterns per se. And many years ago, I started seeing these patients, and they didn't really fit quite like Montigia lesions, and we'll look at those per se. And just a point of history, Montigia missed the diagnoses of these in the index patient for 3 months. They had no x-rays then, of course. But what it is it's a fracture of the forearm with dislocation of the proximal radial ulnar joint. So it can be a variety of patterns. Skeletally can involve the ulna, radial head, and or proximal radius, and the joints can be both the radial ulnar, even the distal radial ulnar joint, and the interosseous membrane. The posterior element can be somewhat predictable, and it may have a chip fracture in the anterior aspect of the radial head and a fracture at the coronoid or distal. And the fellow who best described this was Penrose in 1951. And this was his paper. And he basically tried to duplicate this fracture with cadavers just forcing a load on their wrist with their elbow against a solid board. And it took him a while until he made a little notch in the proximal ulna and then identified it. So is the fragment geometry predictable, is what Dr. Mudgall was questioning. Well, not all of these are fracture dislocations, and some involve more the forearm than the elbow itself. But if you look at these, and the first study we did was in 1991, looking at 13, this is what we saw, that it can involve the coronoid, but the most difficult one may be where there's a triangular fragment of bone in the very proximal ulna. The reason is that unless you have a very stable fixation, and this is not brought into the reduction, it can cause instability and loosening of the plate. In the past, people tried to treat these with casts or IM rods, but it was never effective. And once you got down to here, you started to see an entirely different pattern where the end of the humerus implodes into the ulna, and the radius and proximal ulna here go as one piece. Let me go back to that, because that's important, because that's not likely to have a ligamentous injury, whereas this and this might have associated lateral collateral ligament dysfunction. You don't want to fix these along the side because of that fragment. It'll swivel on it. These still have a good deal of problems. And so let's look at this. Here's that triangular where the arrow is fragment, and that needs to be brought into place. The radius has a very small chip fracture here, and here's what it looks like once you open it, and you've got a defect here. One of the methods of treating these is to try to swing a wire around to bring that anterior component of the ulna back into place, bring the components back and fix it with a longitudinal plate. If it has a very proximal aspect to the ulna, bring the plate bent along the proximal olecranon. And so here's the schematic, the animation. So you see a part of a radial head fracture, and we see a triangular component that's missing from this ulna, and this is where it is. So unless we fix that adequately, there'll be a bending moment that this may go on to a non-union. Using this wire loop, it helps bring back that fragment. In this patient, there was a very substantial lateral instability, so a temporary external fixator is used, just 2 or 3 weeks. And then here's the realignment, and at a couple of years fixation with a good function. Now, the subclassification that made it difficult, it's not a Montigia. And it was described in the French literature at the turn of the 19th to 20th century. But this is from a Belgian book by Lambat in 1905. And so this is a different injury where the end of the humerus implodes into the proximal ulna and olecranon. But it's different than the Montigia because of definition. It's not dissociation between these two bones. This young man, high school student, that's his end of his humerus, and this is all hematoma. And we looked at this group and published and found a lot of problems. But here's the nice way to do this, is if you can bring back the very proximal ulna and implode a smooth K-wire or Simon pin up into the end of the humerus, and then a threaded pin distal to the comminuted fracture, then attach, put the plate over that and attach a distractor, you can bring these components back with a minimal dissection, putting a wire across. And here's the young boy, he's a high school student. And now this boy is actually an orthopedic surgeon, per se. Any questions about that?
Great. That's fantastic. We are almost ready to go on to the next. Dr. J, do you want to get a drink of water?
No, I'm okay.
Okay. Okay, then we'll move on to distal humerus.
Okay. What's the role of CT scan here? I think for articular fractures of the end of the humerus, it's especially very helpful. There are a variety of patterns, and what's the advantage here with the 3D CT is you can eliminate the proximal radius and ulna and be looking square on to the articular surface. And so fractures like these can be very complex per se, and with multiple fragments. So the CT scan is very helpful. Here's another fracture. And the trochlea is disrupted in the medial and lateral columns. And a 3D CT can tell you, gosh, I've got one column that's nearly intact, so I can fix the articular pieces onto that intact column. And that may help in the preoperative planning. So I think this is readily available now everywhere. And it's certainly in an older patient, if there's any question of whether or not it's a good idea to do fixation, whether or not you want to do an arthroplasty, then it's a good way to do that. The other thing is with the CT scan, you don't always have to get it that night, or you don't always have to go to the OR that night, because sometimes these cases can be a little difficult, and your OR night team may not know what to do, so to speak. So I think the CT scan is exceedingly helpful.
So is trans-olecranon approach the gold standard, or should we try to spare the osteotomy and do parallel approaches?
Right. Well, these are the ways that people have been talking about. And there's a great deal of fear about the olecranon osteotomy because you're introducing another fracture. And there are complications as a result. However, some patterns, and that's where the CT comes in, really need a better exposure, and the olecranon osteotomy is very helpful. The other advantage of not doing the olecranon osteotomy is with the olecranon intact, you have a template to build and check your reduction of your trochlea. Well, there are some studies that suggested for very complex fractures, this study compared triceps sparing with olecranon osteotomy, and suffice it to say, they found in complex fractures, especially older age patient, the olecranon osteotomy is a better idea. And so I think that it's a good idea, but what's the problem is the following, as you see, non-union wires and screws. This is a study that was out of Edinburgh, and basically they looked at their experience, not necessarily with osteotomy, but with plate versus tension band. And what they found was that there's more need for secondary surgery with tension band, but it's primarily removing the wires because of contact problems. The problems they had with plate, though, were more profound, with infection and in an older patient with poor skin, that can be a real disaster. This is one of their non-unions with the plate. Very quickly show you how I do the olecranon fixation, because it can be done very predictably. If you make a little V osteotomy, and then two parallel wires go through the anterior cortex, aiming toward the ulnar side, not radial side, and pull it back about a ½ centimeter, and then pass two, not one, but two thinner tension wires, 22 or 24 gauge tension wires, spread them apart, and then do a nice twist, and then take this wire bender, which is a very nice clamp because you can bend it 90 and 90 degrees, and then turn that around and impact it into the end of the humerus, making sure that because you've pulled the wires out before you impacted them, that it won't be too far anterior to the cortex. You can't tell where it is in the cortex. That's why, anterior cortex, that's why I aim to the radial side. There are proximal plates that are okay per se, but it's the technique of osteotomy. So don't feel afraid to do an osteotomy if you need that extra exposure. Is the plate per se. This is a study looking at the literature and looking at that question. But there is fair evidence to support a triceps splitting approach compared to the olecranon osteotomy. So if you have a standard distal humerus fracture, certainly I think the triceps sparing or splitting approach is very effective.
Great. Jay?
Can you comment on your protocol for preventing heterotopic ossification for these types of fractures?
Well, you know that HO would complicate outcome in the standard distal humerus fracture is very, very uncommon. It's usually seen with high energy trauma, with soft tissue injury, or reoperations per se, or fractures associated with head trauma. There was an attempt at a prospective randomized study in North Carolina looking at giving one arm radiation and the other not, but they had to stop it because the radiation caused, they seemed to see more non-unions.
Mhm.
So generally speaking, anti-inflammatory, indocin, all of those things really have no scientific basis. Good fixation and relatively careful handling of the soft tissue. It's very uncommon for the standard distal humerus fracture, if there is such a thing.
Great. Dr. J, do you advocate parallel plating or 90-90 plating, and what's the science?
Well, you know, the anatomy of the distal humerus is such that this is the whole goal. The stability of the elbow comes to a large degree from the relationship of the trochlea to the olecranon sulcus. So we'd want to get that restored as best as possible. Whether or not you put plates along the sides or not has turned out to be not necessarily so critical for most fracture patterns. It becomes a little more difficult when you start to have free-floating patterns of the trochlea split in one or two pieces. So the anatomically shaped plates have been very effective. The difficulty, however, is when it doesn't fit. So be mindful of that. There are some fracture patterns, and I'll show you one, that they're not necessarily easily to fit for standard treatment. But the approach now with the anatomically shaped plates, particularly ones that have angular stability for osteoporotic patients, have been effective. And the data of, again, loading cadavers suggests, well, they seem to withstand load a little bit better. But there are very few studies that looked at one versus the other. So I think it's your clinical experience, but you should feel comfortable in doing what you think will give you good stability. Remember that biomechanical testing to failure in these cadavers may not reflect what they're seeing clinically. It may be much more loading than you see clinically. And the literature supports either one. Are lock plates necessary? Probably not. Lock plates are too stiff. In metaphyseal areas here, they may have a higher rate of non-union. These are the very low distal fractures that can be treated with angular stable fixation. This study showed that. But I'll tell you about 3 plates. The reason being is that some plates, these anatomically shaped plates, may not fit some fractures. So plate contouring, you know, Dr. Mudgall mentioned, should we make sure to know how to place percutaneous pins for distal radius? We should all know how to contour plates because sometimes you may need to use standard plates and contour them like this. So here's a woman I saw who had 20 years before, she's 55, 20 years before had a distal humerus fracture, and now comes in with a very low multi-fragmented fracture. Another picture, and notice this avulsion of the olecranon tip. So this was some of the CT scans, and I thought by using that avulsion, we could do a triceps splitting, taking that piece off. But it turned out that it didn't give enough exposure to this, so we did a more formal osteotomy. And that's where the piece came from. So here's what you're looking at. You're looking at 2 or 3 major fragments and of the lateral column and of the central column. Once you get these together, it's a very low fracture. And so I think if you can contour or know how to contour some of these standard plates, you may be able to use them to wrap around the medial side of the medial epicondyle and on the lateral side as well. And so 3 plates is sometimes very helpful. So here's the defect here, very limited purchase here and here. And that's what it looks like. And she did a pretty well.
Great. Any pearls or pitfalls the audience should be aware of when you fix capitellar fractures?
Yeah, this is a especially unique fracture, and we've come to learn a lot more about them. One of the classifications was by the group in London, Ontario, and keep in mind the 2B and 3B with comminution are more difficult fractures per se. Operative treatment certainly will restore stability, but it's maybe difficult surgery and end up with some dysfunction. Arthroplasty for young, older people may be an option per se, but it depends on their functional activities. And non-operative treatment, in some cases, you can do a closed reduction of just an isolated capitellum fracture. But if not, if it's a capitellar chondral shear fracture, it may block motion. So the interesting thing is, if you go through it through an extended lateral approach and open up and hinge open the elbow, you may be putting pressure on the ulnar nerve. So it's not a bad idea to just do a little release of the ulnar nerve. A straight dorsal incision will allow you to do this, but you can do extended lateral and small medial approach as well. And sometimes, if it's really difficult, an osteotomy of the lateral epicondyle will give you good exposure per se. Now, here's the advantage of the CT scan and the 3D CT scan. What we see here, taking away the radius and ulna, is we see the capitellum and trochlea extending almost completely across the joint surface. But importantly, we see a fracture of the lateral epicondyle and an impaction of this posterior wall. And that has to be elevated. So the CT scan on these will give you a very good idea of what you're dealing with. And you can see how you, through an extended lateral approach, this is a way of fixating that lateral epicondyle, you can get all the way across the fracture per se. And not a perfect flexion, but a functional result. So be careful about these. And if it's a patient with osteoporosis and you want to fix it, I wouldn't move the patient right away. I'd wait 2 or 3 weeks. Remember that we used to think motion is critical in the elbow. Stability is critical. We can always do a reconstruction, a joint release later, but not if the thing falls apart. There are always complications here, and I think good preoperative planning, 3D CT scan, wide exposure, and if necessary, release the lateral triceps posteriorly, elevate it so that you can hinge open the joint so you're looking straight in the front, will give you excellent exposure per se. Okay.
Great. Jay?
Yeah.
So, Dr. Jupiter, one of our final thoughts about what is your approach to the ulnar nerve in fresh fractures as well as in patients who have elbow stiffness? So, for example, after a prior ORIF. And
Right.
then does acute decompression influence the outcome of those patients?
Right. A lot has been more recently written about the handling of the ulnar nerve, and it's not quite conclusive one way or the other, but one of the better studies came from Toronto and the Canadian group, and they followed patients up to a year after they had internal fixation of their elbow, and found a lot of patients have sensory changes early, but the vast majority of patients improved. They were not transposing the nerve. For me, I've always elevated the nerve about 4 to 6 centimeters proximally and 4 to 6 centimeters distally, freeing up the two heads of the flexor carpi ulnaris, because that's where compression occurs when you get a stiff elbow or swelling. One thing to keep in mind is patients who have had elbow trauma, who were doing okay, or you operated, they were doing okay, and start to lose motion and slowly start to develop pain, 4 weeks, 6 weeks, that's the ulnar nerve, if there's no evidence of heterotopic bone or whatever. So study the hand. If they have weakness of the intrinsics, sensory changes, maybe get an EMG, but release the ulnar nerve, and that will abort the evolution of stiff elbow. But the handling of the ulnar nerve is individual. Certainly, if it's in the way of plates, then it needs to be moved anteriorly. But otherwise, there's probably not hard evidence that all the ulnar nerves need to be initially transposed, meaning moved out of their normal path around the cubital tunnel.
So that was fantastic. We, in the interest of time,
Yeah.
Dr. Jay, we'll just have you give us an answer to the last question before we stop. What pearls can you offer the audience to prevent non-union and malunion in the hand, and technical tips to address these?
Okay. There's the tip of the ulnar nerve. Okay. Well, malunion is particularly, it's not simply deformity. It affects, as you can imagine, the arc of motion of the hand. How do you prevent it? Well, understand the adequacy of treatment. If you have a difficult treatment, a high energy trauma, we often may see one of the fractures not heal in a normal alignment. And realize that some involve the joint, some are outside the joint, but the deformity is can be varied, and it's very hard to figure out per se. Let me just get to, one thing is a spiral fracture in the finger. You can reduce it, but you may not be reducing the fracture. You may be twisting through the joint. And remember to buddy tape a rotated spiral fracture. Will fool everyone for a couple of weeks, but once they take the buddy straps off, it may not fool the patient very long. So this is in good alignment, but once it's off, it's a rotated spiral fracture. Non-union is mostly from trauma, we say, or surgical intervention, and inadequate K-wire in bad trauma is probably the most common thing we see. This is a patient who had, you see how the K-wires cross in the fracture, keeping the fracture fragments apart, or this is a failed internal fixation per se. So those are the things that can lead to malunion and non-union per se.
So
one more thing, the treatment is good preoperative planning. Good preoperative planning and the use of K-wires. So if you put your K-wires perpendicular to the fracture, to the malunion proximally, and perpendicular to the fracture or malunion distally in two planes, you can use your K-wires to help realign the bone after you've done the osteotomy. Okay.
that was absolutely fabulous, Dr. Jupiter. Thank you so very much. If you stop sharing your screen, I'll just share a couple things with the audience.
Okay.
To all of you who have stuck around, thank you for staying. We will be sending you a survey right in the next few seconds. Please feel free to answer the questions and fill it out. And what we're going to do is I want to share with you what we're going to be doing next. We got some very good sages coming up. Dr. Stern will join us in a couple of weeks, and then Dr. Shekhar. This program may change, and you will have to register separately for each session. But you'll also be getting a link to the YouTube recording of this webinar that we just did. And for those of you who have already logged into the Hand Must Know series, this Thursday, May 14th, we'll be talking about the mangled hand principles for addressing it, as well as the video on the PIA flap. Finally, Dr. J, on behalf of the North America Hand Education Committee, thank you so very much. It was spectacular. A shout out to Angel, who has run our AV, and to the rest of the AO North America team. Jay Bridgman, thank you.
Thank you.
Good night, everyone. It was fantastic.